Good afternoon and welcome to HealthSystemCIO.com's All-Stars panel, the State of Interoperability, produced in partnership with CHIME, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Omnicell. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We do have, as I mentioned, a simultaneous tweet chat going on. You can view it in the media viewer panel on the right-hand side of your screen. It's going to be hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can view it in the WebEx media viewer, and you can participate if you want to go in a separate browser or on your phone by using the hashtag HSCIOchat. And we will have a few things going on in your panels. The tweet chat will also have some live polling, and the Q&A box is how you submit your questions. You can do that at any time by typing it into the Q&A box. Leave the default set to all panelists. We will take those later in the program. And you can download the deck by using the URL on your screen or a shortened URL, which is at the bottom of each slide. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our main panel discussion, featuring Russ Branzell, President and CEO of CHIME, Mark Probst, VP and CIO at Intermountain Healthcare, and Bob Cash, VP of Provider Relations with CLASS. Okay, so we're going to jump right into our discussion. Russ, can you give us an overview of CHIME? Russ?
Sorry about that. Got to learn to use the mute button. Thanks for having us today. Appreciate so much all that you do for us. And CHIME, or the College of Healthcare Information Management Executives, is a professional association which represents right now about 1,900 CIOs, mostly from the United States, but also worldwide. Our job really is to help the CIOs do their jobs, to educate, to network, and really try to level the playing field so all can advance in the healthcare IT industry. We also have members from the vendor community. We call them our foundation partners. We have about 150 of the most influential foundation partners that are part of our organization. And we try to pair those up and match those up to really solve the big issues that we're trying to work on. Obviously today, interoperability being one of those. And so we appreciate, again, you having us on the call today.
Oh, appreciate you being here. Mark, a little bit about Intermountain?
Sure. So Intermountain Healthcare, we're an integrated delivery network. We're located all throughout Utah primarily. We have one small hospital in Idaho. So, we're very much focused on the state of Utah. We have 23 hospitals, about 200 clinics, almost 2,000 docs that we employ. We have a fairly significant health plan called Select Health, and it's the largest healthcare insurer in the state of Utah, which has been a key component of our strategy. I think one of the interesting things about Intermountain Healthcare is just how data-driven it's been, being one of the first to really apply information systems in healthcare and certainly create electronic health records. We've had a lot of data for a lot of time, nearly 40 years since Dr. Homer Warner built our first EMR. And we just really are focused on using data to improve care and to improve the quality and cost of that care. And I think we'll get into a little bit of that as we talk interoperability today. So, Anthony, thanks for having me on, and I look forward to the discussion.
Fantastic. Bob, a little bit about CLASS.
Yes, CLASS has been, for 20 years, measuring healthcare IT vendor performance in the market by talking to providers, like many who are on the phone today. About 95% of our research comes from conversations that we actually have with healthcare providers, and we're able to amplify those comments by sharing that information back to the provider industry and working with vendors to improve by sharing that information with them. And we have, among many of the segments that we evaluate, been looking at interoperability for the past 3 or 4 years and measuring and reporting performance and movement in that effort. So we're happy to be a part of this conversation, and I'm especially happy to be on the line with Russ and Mark.
Excellent. Yes, we're looking forward to hearing about some of the results from the class work. Russ, I want to start with you on the next question. I just want to do this to kind of set the stage of where we are. Let's first talk about a positive example of how interoperability is working today. What are some of the things that we can do that maybe we couldn't do a few years ago?
I think probably the greatest mark that we've made on the industry in interoperability are really inter-organizational. Now that we've reached the levels of EHR adoption, of overall technology adoption, what we're seeing is within organizations, and we've got probably one of the best examples in Mark's organization, Intermountain, but there's examples all around the country, now even around the world, where the organizations themselves are able to work in an interoperable environment to share the data around an individual patient. The degrees of interoperable data flow, even sometimes multi-vendor vectoral, is being solved within the microcosm of the health system today. And what we're hearing from and seeing from our CIOs, and we've made a lot of trips to their facilities, is the establishment of a patient-centric environment where everything flows around the nucleus of the patient, which is a fundamental change and a shift that's occurred over the last few years, if not the last decade. We've seen a fairly radical shift in that mindset. And so there is a positive nature for the patient, for the engagement of their care, inter-systems, meaning inter-organizational, and I think that's probably the greatest positive move that we've made.
Okay, very good. I want to get our first poll question out there. So let me go ahead and launch that. And it is, as you see, you should have a poll should have popped up on your right-hand side. Overall, do you feel the industry is in a good place when it comes to interoperability? Russ just talked about some of the positive things that are going on. So go ahead and answer that poll question, and we'll discuss the results in a few minutes. Let's go with Mark on this. Mark, I know you've been an outspoken critic of the lack of interoperability in the industry. So why don't you give me an example of something we can't do that we really should be able to do? And I know that it's frustrating.
Well, things we can't do. I got a big, long list. Starting at the top, we can't accurately identify patients, which is a pretty key component to interoperability. We're getting better at it. There's some good momentum. I'm really proud of Russ and CHIME and the initiative they've kicked off around a national patient ID through the HeroX program, and hopefully we'll see some benefits there. But really, we don't have true interoperability. Right now, if you look at the level of interoperability, we can move some information between organizations. Some of that's through a PDF, some of that's actually even discrete data. But even that discrete data, because we haven't come up with an appropriate level of standards in the country, is not completely usable or computable. So because we can't do these things, we really can't leverage the power of computers. And the first question you asked about some of the positive examples, I liked what Russ was saying. At Intermountain, we've had a lot of success in being able to increase quality and lower cost by having this computable data, by having the computer really play a key role in what we're trying to do. And because of that, Intermountain Healthcare is the lowest cost per capita provider of healthcare in the country. Now, it isn't uniquely because of computers and our ability to compute data, but it plays a major role in it. So I really don't think we can leverage the power of computers. We can bring text documents, or we can even bring some information to the point of care for providers through interoperability, but we really don't have true interoperability. To me, interoperability and the movement of that data should be free, and it should happen just free-flowing, but because we don't have some very important components in place, it's not. It's still very expensive. It's very clunky, and so we might be on the right path, but we're going way too slow.
Right, right. All right. Well, look at our poll results, and you should see those on the right-hand side of your screen. Bob, does this answer surprise you? 81% say we're not where we in a good place. 19% say we are.
Yeah, not at all. We're not at the point with our research this year to actually give a percentage, but looking at comments this just over the last couple of days that have come in from our current research, the vast majority of people that we talk to are still saying that we're a long ways from where we need to be. I just was looking at one that just said we have a horrible time sharing data. We still fax too much data, and we receive too many faxes. You know, it's everything from that to the issue of not getting the information. You can get the information, but it's not in the workflow. It's not impactful. It's hard to locate. So plenty of challenge still out there, even though people are accessing information. It's not in a way that's real usable.
Russ, your thoughts on that 81% to 19% split on the poll?
I'm not surprised at all by that. Actually, well, I guess maybe I am a little surprised that 19 think we're in a good place. And maybe that's just because in a microcosm, it depends on what you're judging. Again, if you're inside of a health system, you probably feel like you're in a pretty good place. If part of your frustrations are trying to get information and share data at a macro level across systems, across the state, across a region, the 81% probably makes sense. And I don't know if we can beat the drum that Mark mentioned earlier any harder, and that is till we get to clear guidance on standards, requirements, and in most particular for us, we believe that the very beginning step of this, which should have been clear patient matching, it'll be very difficult for us to advance, and that number of 81 will probably be continued frustrated moving forward.
Okay. Let's go with our next question. Mark, we're going to go with you on this. Why do you think, and maybe in addition to what you've already said, why are we not where we should be in terms of interoperability?
Well, at a very basic level, we have an infrastructure problem. And I've used many times, and even in webinars like this, the example of the railroads. But if you have a massive infrastructure in place, which we now have, you know, because people were interested in EMRs before meaningful use, and then with all the emphasis that meaningful use put into implementing these systems, we put in lots and lots of expensive infrastructure. So think about railroads and railways and how expensive that is to put in place. But we didn't do it with appropriate standards in place. So to get to interoperability, we either have to look at changing that infrastructure at a very basic level or spend lots and lots of money doing kind of unnatural things to make these systems speak to one another. So my belief is we're here because of infrastructure and a lack of standards, and they weren't addressed, you know, nationally or correctly through the Meaningful Use program, and now we're dealing with that challenge. We also have the negative side of competition between the major vendors of these EMRs, and you know, that competition is continue to grow my footprint. In some instances, maybe even maintain my footprint because of, you know, my abilities, and that I'm not going to speak with others, because if I start to speak with others, maybe that makes it harder for me to maintain my footprint. But I would go to the basic answer to why we are where we are. It's infrastructure and the fact that we didn't deal with that up front.
Bob, what are your thoughts on that question?
We're actually hearing the same thing, so I will say that. And in our last year's report, standards and infrastructure were at the top of the list of issues that providers are saying are the issue. I mean, some of it is just a maturity issue in terms of the industry maturing. Meaningful Use did serve a purpose in that virtually everybody's connected. That's the good news. The bad news is that the information we're receiving isn't as useful as we need it to be impactful and beneficial to clinical end users. And so it's a maturity issue in large part, and there's a desire for us to move faster, and we likely need to do that, but we also need to do that in a smart way. So I think the issues that Mark mentioned are clearly the issues we're hearing regularly, and it's not a large list, but it's a very challenging list. So we do need help in moving those standards forward. Sometimes it's not a matter of not having the standards, but they're not quite mature enough to be implemented in a large scale.
Very good. Russ, I want to go with you on the next question. Obviously, you're very involved with working with government on many issues. What is the government's role, in your opinion, in terms of fostering interoperability? What should it be? And is the government, or has the government been focused on the wrong things?
Yeah, I think if you look at and I like the way Bob used the term, the maturity, part of this was they were a foster of really helping us get to that next level of adoption of the technology itself. You know, we can call it the infrastructure or the base model. And I do think they served a good role of being a catalyst to get people to move in that direction of adoption. What we didn't see along the way, though, was a good prioritization of the clear standards and requirements to adopt that. So we all launched into our journeys, and in many cases headed into different directions. And so Mark's organization may have headed north, and another one headed east and west. Well, we all started from kind of at the same point, but what's happened over a fairly quick fashion is lots of people have moved in different directions, which actually has compounded the problem of interoperability. So what role should the government play? The government does have a convening authority opportunity and has for a long time. They can put out large level guidance, which they have with stuff such as the interoperability framework. What they don't do necessarily a good job of, or should not necessarily always do, is define very specific requirements down to a granular level, because that takes a long time and a long period of work, which we've seen with everything from national patient identification to clear data definitions to clear even exchange requirements, which those things take a long period of time and also places them often at a disadvantage because they're trying to look for either the perfect answer or how to satisfy too many stakeholders. So I think there's a fine line between the role of convening and also aggregating and adopting clear industry standards, and occasionally, when needed, a clear, definitive answer of to do X, and whatever X might be would be in the best interest of the patients in the country, and that should foster a significant jump in whether it be interoperability, safety, quality, but it shouldn't be just for the sake of doing something that the government wants to do, but rather there has to be a clear outcome in that stake.
Mark, we just talked about your trips to D.C., so your thoughts on the government's role?
Yeah, sorry to interrupt, but I wasn't going to let this get past.
No.
You know, in many ways, this is a complex problem, but I think we try, and particularly the government tries to make it, or is making it more complex than it has to be. I mean, it isn't as simple as the gauge of a railroad, but it isn't rocket science either. Standards are something that we've had now for 30-plus years. We've had great organizations like LOINC and HL7, and go through the list of standards organizations that have attempted to develop good standards and even get them deployed across the country, but that has not been effective, and we still are where we are. I feel very strongly that the government has a key role to play in this, and I believe that it's a national safety issue. I think there are tens of thousands, if not hundreds of thousands of lives a year that are lost because we aren't dealing with this, and certainly billions of dollars. So what's the government's role? Fund the definition of a set of standards. Will it be perfect? No. Will it be good enough? Yes. Then enforce those standards over a period of time, giving the vendors and those of us that participate on the provider and payer side time to acclimate to these standards and then get on with it. I mean, we don't constantly debate whether or not we should be driving on the right or the left-hand side of the road. Maybe there's a couple of countries that do, but we don't. And we can do the same thing with standards around healthcare, and we can make a huge difference. But the government's going to have to, get some backbone around this.
Okay, very good. Now we're going to go with our next poll, which you will see in a second there. Okay. You should see the next poll open to your right. Very interested to see the results on this one. Have you personally observed vendor activity that could be described as information blocking, yes or no? Interesting thing on this, which I'd like to present to our panel, is that I have heard some of the people I respect most in the industry say, absolutely. I have heard some of the other people who I respect just as much say no. So let's put that out. Let's go with Bob first on this, and I know you might want to leverage and talk about some of your research here. Is there information blocking or not as far as the research shows?
Yeah, in terms of conversations we've had with providers, the answer is no. We have, and certainly that's not to say that there aren't some people who have experienced something they would call blocking, but it's a very small minority. The majority of those who bring it up as an issue don't have direct experience. You know, they will say, I have heard that. You know, such and such does data blocking. But when we talk to people who have actually tried to connect with any particular vendor who might be accused of this, the answer is no, we really haven't had a significant problem with data blocking. So from our research, we haven't seen any indication that would suggest that there's some kind of a sinister plot to block data coming from vendors or providers for that matter, although there are competitive forces at play in some markets that, you know, Mark even alluded to a minute ago that you know, cause people to drag their feet or to cross every T or dot every I. But sinister approaches don't seem to be something that we can validate through our conversations.
Yeah, Bob, don't you see there being a difference between deliberate data blocking and then just kind of normal, this has been our strategy as an organization, and that has caused data blocking?
Yeah, I mean, you certainly have organizations that have figured out how to connect people better, and they're better at it, and they maybe have been more willing to address that more quickly for whatever reasons, competitive reasons, culture, strategy. But again, it's where the organizations are in their own evolution as well that has to do with how successful they are at sharing.
All right, we've got our poll closing here in a few seconds, and then we will share the results. So, see them right now. 62% say no, they have not observed it. 38% yes. Russ, your thoughts on those results?
Again, I think that it comes down to your definition of information blocking. I could have answered this question either way, whether it was my previous role as a CIO or what I hear from the field now from our large group of healthcare IT leaders and CIOs, and that is, if it's outright, I'm going to block this data from flowing to the other vendor, it's probably no. If it's, I'm going to charge you $25,000 for an interface and a small organization can't afford that, and that is often what you hear as a deliberate act of making it difficult to interoperate information, then the answer is probably yes, and some variant in between. So I think, again, this comes down to what the definition to start with is. I don't think any of these organizations have an office of information blocking with a chief information blocking officer sitting there figuring out how to deliberately do this, but they come from a long line of proprietary, unopen sourced information and systems. They are what they are today, and they're working, I think, reasonably hard to try to make the world a level playing field to exchange the right data at the right place. But with the wrong definition or the right definition, you could answer this question either way, and I think that's probably true of almost anybody.
Well, let's stick with this. I'm actually going to bring in an audience question because you touched on it, Russ. What about pricing interfaces to a level that ensures none of the entities can participate in interoperability? So, Russ, any more on that?
Yeah, I was talking to a CIO in the Washington, D.C. area recently who was getting interface quotes for the exact same interface. One was $3,500 and the other one was, I think, almost approaching $50,000 for the exact same interface. And so I think that's probably a great example of if there's a reasonable cost for the work being provided, because they've got to pay staff on the other side, there's work to be done, There's some level of custom nature of the software usually that the organization did themselves, so therefore there needs to be some custom interfacing. I think there's a reasonableness to this, but pricing something of that much of a scale of difference for a small organization is probably unrealistic. And I know some don't even charge at all anymore for it because they have enough margin on somewhere else to absorb it. So I do think, again, that there's some degree of this that's reasonable, but probably not in the 5 figures, especially for a small organization. They just can't do that. So then you would end up backing into that definition.
Mark, any more thoughts on that if we talk about intent? I mean, if you want to, let's say the intent is financial gain. They're for-profit businesses. You want to maximize your revenue. Where does it become nefarious?
I think that anything that prevents patient data from being moved to help improve the care that we provide is nefarious and wrong. But again, I wouldn't go that these big organizations are really trying to do that. Where I think I see a little more of the question you had around the cost of interface and that kind of information blocking, as we see things like FHIR and the ability to use these open APIs to bring functionality in and share data across, differing systems, so that maybe I have a growth chart that, is built like an app, and I can easily surface it through FHIR into another system, one of the major vendor systems. I could see where, I have seen where some of the vendors are starting to say, we're going to charge a fairly hefty rate for you to be able to do those things. And that to me might be, hedging on, we see some of our hold on the market slipping away if we allow these open APIs. But from pure data sharing around a patient, I've yet to see anyone that's intentionally trying to block that. But technology itself has become a block for the reasons we talked about earlier.
Very good. All right, Russ, let's go to you with the next question. It's an interesting question, I think. If things don't go well, if we don't go in the right direction, can you give me a future state, sort of a scenario of here's what's going to happen if we don't get our act straightened out?
Well, I think the minimum of the worst state is we're at the status quo, which is where we are today, and we're in this limbo state of we've adopted technology, but we haven't taken care of the benefit, really taken advantage of the benefits that we should have, which I think in itself is almost criminal for the amount of money that we've spent, the billions of taxpayer dollars that have been used, as well as a multiple factor higher of organizations and the money they spent, which really is a wrong to the patient themselves. I think there is, though, even a greater level of concern is the more we've adopted these technologies, and there is the possibility of actually making the system worse instead of better, and that you become siloed of this electronic information, and there's actually a jeopardy to some degree, and we're seeing this with Joint Commission data and several others, that there are actually harm that can be created in an electronic environment, creating safety and quality issues just because we've gone to an electronic system. And I think if we don't proceed forward, we won't see the benefits, and we will either compound or at least at a minimum suffer from the sub levels of quality or safety issues that we have today.
Very good. All right. Bob, let's talk about one second. Give me a positive vision, Bob, of the future state if things go well. Based on things that people are trying to do or wanting to do. What are your thoughts on where we can be in a few years if we get this right?
Our current research, frankly, is looking at the clinical end user's experience with receiving information from outside their organization. So that's the perspective I'll bring to my response. And what we believe clinicians want based on the conversations we're having with them is to have access to the information that they want, when they want it, where they want it, within their workflow, and in a way that's impactful to to patients. So, and I think that's the right vision. We don't need to share information just for the sake of sharing information. We need to share the information that is actually needed to impact patient care, which is, you know, what we've been saying here. And again, our current research is showing that we're a long ways from that panacea or ideal today. So I think that would be the vision of the future that would be positive, is that, you know, you can actually get the information that's impactful when you want it, where you want it in the workflow. Right.
Mark, you're very, you know, obviously you're all plugged in, but you're extremely plugged into what's going on. For you, give me a realistic vision, not positive or negative, just where you think we'll be in 3 years based on how things are going today.
We'll be very slightly incrementally better than we are today. We're going to see more of these open APIs used, which are going to allow for a certain level of interoperability that's better than we are today, but not where we need to be, and not to, you know, that will achieve the advantages that we can get. And just, you know, look politically at what's happening. We're going through an election year. Things are going to change. Once it does change, you know, regardless of who's elected president, administrations are going to change. It's going to take people time to get their legs back underneath them. So, you know, I hate to sound bearish, but I'm a little bearish on our ability to do what needs to be done over the next few years. Now, 10 years out, I think we'll be in a different picture.
Okay, so 10 years might be looking a little better.
I hope so.
Okay, so that's something to look forward to. All right, now we're going to break for a moment. We're going to bring in our sponsor. We're going to hear from Ken Perez, Vice President of Healthcare Policy with Omnicell. Ken, thanks for sponsoring. Thanks for joining us today.
Anthony and the Health System CIO team, thank you very much for hosting this exciting forum, and I've enjoyed listening to it and learned a lot. Thought leaders from CHIME, Intermountain Health, and CLASS have done a great job, and I wanted to share a little bit about my role at Omnicell. I'm charged with helping our company keep abreast of healthcare policy, regulatory, technology, and market developments. And as we all know, the healthcare industry is going through a period of profound change. And as we've heard here today, interoperability is a major element in that transformation. So I want to take a few minutes to share with you Omnicell's perspective and reinforce the importance of advancing interoperability. I believe our company started talking seriously about system interoperability 4 or 5 years ago. And since that time, obviously much has changed. Today, with the importance of data universally accepted, there's great need to have systems communicate more effectively to improve patient care, facilitate patient engagement, and support new delivery models. And now more than ever, system interoperability is a critical part of the medication management delivery path. And we work with thousands of hospitals throughout the world to optimize their medication use process and create greater efficiencies. And we hear from many people, CIOs, directors of pharmacy, CNOs, and other clinical leaders about their expectations regarding system interoperability. As we engage with our customers, we have gained, I think, a deep understanding that connected data is a key enabler to improve patient safety, increase efficiency, and reduce costs. So as a result, we intentionally design our solutions to help accelerate solution interoperability across a wide range of disparate systems. Our aims are twofold. One, to simplify the medication use process. We major in that. And two, to prevent medication management problems such as missing medications and medication errors. And we're also diligent about being forward-looking, supporting industry standards and best practices. So, for example, Omnicell is a signatory to the Office of the National Coordinator for Health IT's Interoperability Pledge. And furthermore, we are actively working to apply analytics to data, leveraging system interoperability to improve clinical and financial decision-making as well as outcomes. Now, we approach solution design in a deliberate, thoughtful, and collaborative manner. We focus on getting the information in the right format and bringing the various players together. I want to give a recent example of this, and it is especially related to how we engage directly with our customers regarding interoperability. We held a customer forum in May with Epic at a large children's hospital. The goal of the meeting was to generate ideas about what can be done by the vendor partners to help address some of the hospital's workflow efficiency challenges. It was a productive meeting. So thank you for allowing me to share a bit about Omnicell, and our approach and our philosophy about interoperability. The more effective healthcare system of the future we all want cannot be built without your efforts to develop, support, and apply best practices. We are pleased to have sponsored this webinar today to help underscore and promote the importance of interoperability. Thanks a lot.
Thank you, Ken. Really appreciate you sponsoring and your participation. Okay, we're going to go to our audience Q&A. So we've got a few questions in already, and as I mentioned, type your questions into the Q&A box, the lower right-hand corner of your screen. Leave the default set to all panelists. Russ, let's start with you on this question. Who has the most influence for interoperability change? Government, payers, healthcare organizations, or vendors?
Well, right now, unfortunately, I think right now we're in an environment where the vendor community within Washington is where most things are being generated. Now, I think what we're seeing is the private sector itself starting to take control of the things that we should, and not only try to influence what's occurring in the government sector, but just importantly, take control of the standards and take control of initiatives such as National Patient ID Challenge is just a small example, because I think we are the right people to solve this with the right help from our vendor partners as well as appropriately at the right place, the government.
Okay. Next question, let's go with you, Mark. How do you see patient privacy impacting interoperability?
Wow. Security and privacy. Well, security and privacy is a massive issue, and it's really hard to manage. I mean, the biggest challenge for me in privacy is the sharing of these records, because, you know, if a patient trusts me and my ability to secure the privacy of that record, and now I'm going to share that record with other people, in essence, you know, we're now duplicating and then triplicating, and then, you know, we're really creating more and more of these records that could be hacked and taken by people. So there is a risk there. We're certainly spreading out that risk amongst more people as we interoperate and share the data. But I think the net benefits of interoperability and our ability to share this data for the health and the quality and the cost of healthcare, you know, far outweigh that risk, and that there are things we can do to protect the data.
Very good. Russ, let's go with you on this one. Do consumers have a voice for change, and if so, recommendations?
Absolutely. In the end, the consumers are the dollars, and though they may be working through insurance or whatever the case may be, what we're starting to see is this concept of patient engagement going from a nice thing on the side to truly a driving force in our industry. And it can happen at a local level where patients engage with an organization like Mark's in a very collaborative way to improve care. But what we're also seeing it on is on an advocacy and large macro level in Washington, where patient advocacy for change is actually creating quite a bit of attention, because obviously when constituents speak, whether in large group or in small group, to their lawmakers, to agencies, this has a large influence on them. So what we are seeing is the emergence of the private sector component of patients themselves taking a large role. But just importantly, there's a role for patients to play in the management of their information, whether it's through our partnership with Open Notes, where they can see their information and partnering one-on-one with their physicians, or from an aggregate level of taking control of their information for their personal wellness. Patients should be getting involved in their overall care continuum.
Mark, you want to touch on that, the role patients might have in fostering interoperability through things they might request or demand?
Sure, it's very similar to what Russ just said, but isn't it interesting how this is a topic? And, you know, when I first started on the policy committee, we didn't talk standards. You know, we talked functionality and getting these systems out, which was, you know, part of the problem. But later in the process, you know, 3-4 years into it, as people started thinking more about interoperability and these challenges, the concept of standards came up. And now if you go to any meeting anywhere within our healthcare, you know, whether it's CEOs, CIOs, CFOs, the term interoperability standards and these capabilities are coming up, and I think you're going to start seeing it leak into the public as well. And as that happens, yeah, I'm with Russ. I think that level of advocacy and those voices coming up are going to really help us move this forward. So big role, and as they become more educated, they're going to the consumer is going to play a much more important role in getting to where we need to be.
Very good, Bob. I just want to make sure we've sort of extracted all the information you wanted to bring to the table today. Any other points regarding this topic from your research that you wanted to share?
Yeah, I'll just share a couple things. First of all, it is interesting. We're having two very different conversations as we talk to people. I kind of call it the three bears scenario. We have a lot of mama and papa and very little baby bear. People are either getting way too much information so that they can't parse through it and use it in a way that's meaningful, or they're getting so little that they can't do anything with it. So we have this wide range, and we're finding very few folks that are saying we're getting exactly what we need, where we need it, and how we need it. And so we have a ways to go before we have the baby bear scenario. Just one quick example, and we've looked at this from two perspectives. One, what's your experience if you're getting information from your same EMR outside your organization? And we've asked if you're getting it from different EMRs. And not surprisingly, it's better with your same EMR, but even in that scenario, you're at somewhere less than 10% actually can get the information they want, where they want, in the workflow that's impactful to patients. And then that number drops from there if you try to work with different EMRs. So again, we're simply learning what I think everybody said earlier with the 81%, that we're a long ways from the ideal. There is optimism. There certainly are people talking about different things that they think might make a difference. Commonwealth comes up commonly as something that people are laying some stock in. But again, there's a lot that we can't verify yet. A lot of these ideas are simply ideas and not verifiable. FHIR comes up pretty regularly as something that people are counting on as a solution, and in some instances it's working. But broadly adopted is not the scenario that we're hearing or seeing yet.
Very good. Thank you, Bob. Russ, I want to ask you, before we go, it's an important question. What do you want your CIO colleagues, those CHIME members and non-CHIME members, to do to get us to the right place?
Well, I think there's two things. They continue the great work they're doing inside their organizations, and not just optimizing or not just adopting technology, but more importantly, partnering with their care providers and continue the fight to improve care and quality in their organizations. But I think the big thing that we're starting to see is truly this commoditizing of information and best practice in the industry, where we're sharing things like today, but in even more forums where we're sharing very detail-oriented thoughts on how to leverage interoperability where there's successes already and learn from each other. And whether that's stealing and blatantly giving it away to others, I think that's a different model that we have. There should be no competitive nature to interoperability. We need to level that playing field in which this is shared in such a way. And though we are pessimistic at times and maybe too often, I think with the right degree of sharing, the right degree of openness in all the parties involved, we can get this hopefully solved much sooner than the 10 years that are out in front of us, and maybe in pockets or even in small areas of success, see some major strides of change in the next few years.
Mark, thoughts on what you'd like your colleagues to do to help us get where we want to go?
Yeah, it starts with advocate. I mean, we have got to continue to push our legislature and our government to help us move this along. They are in the position to do it, and I can't overemphasize what a national issue this is. It's our financial viability, it's the security of our nation, if you look at things like defense, and it clearly is the right thing for our population. You know, so part of advocating is get educated, understand the issues, and I think more and more we're learning them, and then educate others on your boards, on your leadership teams. I mean, just the sound has to get out there, and it does need to get into the consumers, as we talked about earlier. You know, show what the potential is. It's massive. It is not small potential, and if you need help with that, send me an email. I'll be happy to send you all the material you'd like. So, you know, make noise. Let's get people educated. And then I think finally, we can't be part of the problem as CIOs, you know, in healthcare. And you know, the way I see some of us being a problem, and I will include myself in this, but it's overall vendor allegiance. You know, if our vendor allegiance is more important than trying to get to good interoperability, we need to question ourselves and our vendors. They're getting better, but I think we have to be careful there. And then we also can't be trying to save jobs. You know, I've got a whole team that does a lot of mapping and interfacing and those kind of things. I'm not trying to save IT jobs. I'm trying to save the lives of the people that trust us. So those would be my my impassioned thoughts.
Wow, very well said. Very well said. So I just want to get one more audience question in front of Russ before we get going. What can we learn from around the globe on what has worked or hasn't worked for interoperability? So not necessarily need you to give specific examples, Russ, but what is the potential for learning? And I know CHIME is looking internationally, so the potential there to get some solutions in this area.
You know, I think the thing that we've seen out there is there are places out there that are doing it much better and at a much more rapid pace than we are. Maybe not the same scale, much smaller countries, but what we have seen is a degree of deliverancy, and that is whether it's the vendor community, the government sector, or the provider community, is there's a deliberate and overt agenda to make this work. And what we're seeing is, and Mark said it very well just a second ago, is we have to advocate for that this becomes a national agenda without agendas, outside agendas, that is, to solve this for the patients of this country. And what we're seeing is in other countries, and Mark and I did a tour of one, I won't give a specific example, but what we saw was it is a national requirement to participate in interoperability, blatant interoperability, or you can't provide care or can't do business in that country. Now, I don't know if we need to get to that degree, but boy, what that did was instantly level the playing field for the patients of that country. And eventually we will have to at least get the same outcome, which is interoperability for all.
Well, I can't think of a better ending. Well done. When we close out our event today, when you close your WebEx, please take a moment to answer our post-event survey. It'll take you less than a minute. I want to deeply thank our panel, who's very passionate on this topic, Russ Branzell, Mark Probst, and Bob Cash. I want to thank our sponsor very much, Ken Perez and Omnicell, for helping make this event possible. You'll receive an email when our archive recording is up on our YouTube channel. For those of you with the CHIME CHCIO certification, attending our webinars gets you 1 CEU. Sponsorship opportunities, you can contact Nancy Wilcox, and if you need a certificate of attendance for another program, you can see the final slide. And you can go to our website to see our upcoming schedules of events. So again, I want to thank our panel, our attendees, our sponsor, and everybody have a wonderful day. Thank you.
Thanks, Anthony.